Candidate 1, your 10 minutes start now.
Okay. Hello, madam. Good afternoon. I'm Dr. Karti here. Yes, how can I help you today, madam?
My son here, Ali. Ali has been limping, and he's not his usual self. He's just been limping on one side.
I say. Okay, I understand that it must be quite, distressing for you to see your son in that position, right? Just want to clarify a bit. He had a episode of URTI 2 weeks ago, is it?
Yeah, he has a fever,
Mm-hmm.
some running nose, and sore throat.
Okay.
He's recovered. He's recovered well now.
So, okay. So how is his pain? That you told me that he's limping, but how is it? Is he now today?
He can still walk, but he's limping. He can still bear weight on it.
I see. So did you notice, apart from that, the limping, did you notice any other swelling anywhere else, madam?
No, I initially he said it was the knee, and then I don't know whether it's the knee or the hip. It's just one of the two joints, or maybe one of them involved. I'm not very sure.
Okay, I see. Okay, madam, it's okay. Later we'll can examine. Later I can examine Ali and we can work it out together. Okay. Apart from the swelling, pain over the knee and the hip, is there any other skin rashes that you notice?
No, I don't notice any rashes.
Okay, that's good. Is it the first episode for him to limp like this?
Yeah, I think so. He was, apart from playing, had a fall maybe when he was 1 year old.
Okay,
Yeah. Otherwise, he's generally a very happy boy.
I see. Is there any this time? Is there any fall before he had that limping?
I haven't seen. I don't recall him having a fall.
Okay. How is his appetite like now, madam? Is he? Is he?
Appetite is good. He wasn't. He wasn't eating that well when he had a cold, but now he's back to his normal self.
Okay, that's good. Did you realize that whether he's losing his weight or what like that?
Uh, no, I don't see him losing weight.
Okay, that's good. Okay, sorry to ask, is there any medic? Sometimes this limp pain can be some actually there are few causes lah that it can be. So I need to clarify a few things. So the family members have any family members can bone cancers or any cancers?
No, father was asthmatic. I don't remember. Yeah, I can't recall how grandparents. They died at fairly old age, about in their 70s and 80s.
Okay, madam. Madam, who's the caretaker of Ali now?
Yeah, he lives with me and my husband.
Okay. Are you sending him to nursery or anything?
He's 3 years old, so I yeah, so I just sent him to a nursery school. Just started nursery school this year.
Okay. So ask Ali. Ali is happy going to the school?
Yeah, he's going to the school. As he missed out only last week when he had that cold, running nose and sore throat.
Okay, madam. Okay. So madam, from this, right? I need to examine him further. I'd like to check his anthropometric. Like I need to know his weight, height, and his BMI.
Yeah, his weight and height are appropriate for his age.
Okay, and his vital signs, his BP, pulse rate, temperature.
No.
Okay, and I'd like to do a specific hip examination to check one inspection. I'd like to see is there any is there any redness of the skin? Then I'll palpate for any warmness. Then I'll see is there any swelling noted. Then see whether it's any tenderness or not. Then I'll look for any range of motion. Is it okay, madam?
Yeah, so his hip is on the left hip is restricted. His
Okay.
left knee also restricted movements.
Okay. Is it any specific position? Like is it abducted, adducted?
Yeah, so at the end of movements is restricted. In all movements is restricted.
Okay, okay. So madam, from then I'd like to just complete by checking his lungs and heart as well. Then I'll proceed, madam, I'd like to proceed with some investigations lah. Okay, I'd like to take a full blood count to check his white blood cell, whether it's raised or not, and some inflammation marker like ESR, CRP. And then also I'd like to order an X-ray, especially on the hip area, anteroepilateral view lah.
So the full blood count essentially normal.
Mhm.
The urine also normal. The X-ray is normal.
Okay. Okay, madam, from what is restricted? Is Madam, from what I can see, right, from the examination and the investigation, there are a few things that we can think of. Okay, so one is what we call as a transient synovitis. A transient synovitis is a temporary inflammation of the joint over your son's hip because of the recent infection because of the upper respiratory tract. Recent cough and flu. Then otherwise, I also like to think that it could be other causes like septic arthritis, but since everything is normal, so is there anything that worrying you, madam, at the moment?
Sorry, I didn't hear that.
Is there anything that worrying you now?
No, not worries. We just want to see when my son will get better and walk normal again.
Okay. How about any other joints examination? Is there anything else? Any findings on other joints like shoulder, knee?
Other joints are all normal.
All normal. Okay. Okay, madam. So from what I told you, this could be transient synovitis. So I like to give him some painkillers. So that painkillers is what we called as will reduce the inflammation lah, over the joint area, and that will make him feel better. Actually, then his movement can, his motion, range of motion over that area can be improved lah. So I will give him some painkillers, which we call as some ibuprofen, okay, and also I like to you also can do some ice packs. You can actually, that will make him feel better over that region, and I will review him back in 2 weeks' time. Apart from that, if you feel that his condition is getting worse, or is having fever and his range of motion is getting worse, that he can't even move at all, then you can come and seek immediate treatment. Then we can figure it out what's going on later on lah. Okay, but now at the moment, just to reassure you, it's just inflammation. It's just a inflammation over the joint because of his recent runny nose, fever, and cough lah. Is it okay, madam?
Yeah, how long does my son take to recover?
Usually it can recover within 2 weeks to 4 weeks lah at most. So at the moment, we can actually try not to do any, try to restrict some activities. He need to have rest from any activities. Okay, and then when he's sleeping, perhaps you can elevate his hip. You can, raise up some, put some pillows, so that will make him a bit comfortable. And other than that, yeah.
What other investigation can you do to confirm transient synovitis?
What other investigations? I like to do a joint what we call joint analysis, aspiration, if there's any effusion over that region. to rule out.
Ultrasound, ultrasound can pick
Oh,
up.
ultrasound, yeah.
Don't forget ultrasound. Simple thing like ultrasound, you can pick effusion in the joint. Then you can pick. Yeah, you done well. You passed well. But let's go to the slides. I think we got a bit of time, so we spend a bit of time. Well
Okay,
done.
10 minutes done.
Yeah, we'll do the slides. Show me the slide. So we just go next slide. Next slide. Yeah. So it's pediatric. So this is the case study. Go on. Go on. Next. Yeah. This is the history. Go on. Okay. So this is checking. I just did my own. So it's important to global. Hello, I'm Dr. This and that. Have a seat. This and that. Then all this. You score history, physical lesson, examination. Anemia, limb adenopathy. It's important. Why uveitis, rashes? I can tell you later. This is for juvenile arthritis. Which hepatosplenomegaly is also for juvenile arthritis. So the best way, go on. Next slide. Next slide. So next slide again. So the best slide is I do this. This is my approach. Whenever we have pediatric or any constipation, abdominal pain, limping child, always break out into the age groups. So 1 to 5, 5 to 10, 10 to 15. So across the board, you can see, there's 4 diseases that occur across the board. So trauma is very important. You must ask for non-accidental injury. Go back to the slide. So you must the previous one. So trauma is non-accidental injury. You must rule out because this one may be child abuse. You must look out for those things, so you don't miss out. It could be a child abuse case and look for signs of child abuse, like ligatures. I'll tell you, osteomyelitis, septic arthritis. So this 4 is definitely there. Since he's 3 years old, it's transient and ascites has to rule out. Perthes in 5 to 10 and slip upper femoral in 10 to 15. But across the board, you must remember the TOMJ, T-O-M-J, Tom J. Okay, next slide. Next slide. Okay, so step 1 is your specific, what group you must know. Then you look for risk flags. This is the TOMJ. Then since it's 3 years, it's transient synovitis. Next one. 3 steps, So non-accidental injuries, these are the alarm features. These slides all will be given to you all later, so don't copy anything. 9 months, immobile child. You must mention, I look for signs of non-accidental injury, so that will score marks for you. Because you miss, non-accidental means fail already. Okay, go on, next. These are signs. Okay, go on, next. These are all child abuse, which you all must know by heart. You say, I must exclude this. So when they exclude it, the examiner say, oh, at least the doctor is thinking along. So this across all age group child abuse occurs. Next one. This is all cases must be reported. Next. Coccus is so that's how you mentioned septic arthritis. So septic arthritis, the thing is fever more than 38.5, non-weight bearing, cannot wear. So you mean transient synovitis, they can still walk, but in non-weight bearing, they cannot walk at all. And then ESR more than 40, the VBC more than, some say 14,000. When you get this, it's 99.6% is septic arthritis. The other day, I diagnosed a case of septic arthritis based on this criteria. Each one carries 1 point, but you got 4 points. You get 99.6% is septic arthritis. This is primary care. Primary care using 2 observation, 2 clinical finding, 2 investigation, 1 symptom, and 1 sign. Coccus criteria, you must know. And this is occurs across all ages. Next. Then the difference, go on, next one. Next one. Then you go to, these are the flow chart. Next one. Then this is malignancy, also across all. So TOMJ, trauma, osteomyelitis, septic arthritis, malignancy. Next. So Ali will have Ewing sarcoma, since it's 0 to 10 age. Next, you did ask for malignancy, which is good. But you must examine them Juvenile arthritis is many types. So systemic onset has got, this is an emergency, systemic onset. So they got 7 subsets here. So you look for systemic onset, it's got fever, and got splenomegaly here, and you got uveitis. Oligo is less than 4, and then rheumatoid, this one's more than 5, but one is positive, one is negative. Enthesitis and psoriatic, they have psoriatic signs, then undifferentiated. Go on next. See, this is my chart. You can see the most common is the oligoarticular, but life-threatening systemic onset Still's disease, you must mention hepatosplenomegaly, fever, and rash. Okay, so this one is you must see in all cases with sleeping child. Rule out Tom J. Trauma, osteomyelitis, and septic arthritis, malignancy, juvenile idiopathic arthritis with 7 subsets. Okay, go on next. Here's all the mnemonics. Okay, go on. So this is all the in table form. Go on. Next. See, transient synovitis, can still walk. Inflammatory markers can be normal also, but ultrasound very important. Don't miss out ultrasound. X-ray will be normal. Sometimes you get radiation of hip to the knee. Next. Transient, go on. Next. Go on. This is all Perthes, so you must transient synovitis. Go on. Okay, go on. This one you all can read. Later you go back. This one is in Perthes is in 5 to 10 years. But these are all, they are more in boys, but they are very, they are immediate. You must refer immediately. Next, even sleep upper femoral, because just got avascular necrosis of the femoral head, so you must refer appropriately. This is 2 males are more prominent. Same with sleep upper femoral epiphysis. Next, but you don't consider it Ali because Ali, there are these obese, poi, and then this abduction and internal rotation affected. This one they move movement of the shaft of the femur. Okay, next. But this is a difference. I drew this table up, so you all can read about it. It's an endocrine. Okay, go on next. That's it. So that's limping child. Okay, so the 4 things you must mention to impress your examiner. So in every case of pediatric, I guess it's a bit too late now to write out differential diagnosis, but you always go into age group, this age group. So in constipation, so certain thing is across the board, but certain diseases in pediatric occur in certain age group. So this is an example of a pediatric, where the limping child can be classified into 0 to 5, 5 to 10, and more than 10 to 15. Good luck in your exam. Thank you, Kati.
Thank you, Doctor.
We go to the next one.
Okay.
Yeah.
Second volunteer, Alia.
Yes, Doctor.
Okay.
Hi, hello. How are you?
Hi, Dr. Chen. Yes, I'm
Hi.
fine, thank you.
Thank you for volunteering.
Yeah, thank you for this session also, Doctor.
Don't take it as an exam.
All right.
Enjoy it.
Okay.
We'll let them read, and then this one is
Your 5 minutes start now. Your 10 minutes start now.
All right. Okay, doctor.
So what are the possible differentials from your findings here?
Okay, since the deterioration is quite acute for the past 3 days, I would think of delirium. I would exclude like cardiovascular attacks such as having stroke, maybe electrolyte imbalance, sepsis, maybe secondary to urinary tract infection, head trauma causing subdural hemorrhage, certain drugs that can cause delirium such as certain maybe certain drugs and then also maybe some medication that may cause she's on opioid, if I'm not mistaken, maybe can cause the constipation and cause the delirium also. Otherwise, might be due to the worsening of dementia. And if for psychology, might be to major depressive symptoms. And other organic cause, maybe hypothyroidism.
Okay. So how do you differentiate delirium from dementia generally? How do you differentiate based on
Okay, so the differential between delirium and dementia, delirium onset is quite an acute onset, while as
I just checked the hello, who is that? Who is that? Oh. Sorry, the dentist is here. Yeah. Sorry. Go on.
okay, so delirium is usually acute onset and sudden onset, while dementia can be like gradual and progressive. And then in delirium, there might be times where a patient is lucid, means that there are times that patient is stable and then falls back into this delirious state. As for dementia, maybe usually patient is always in the same state. And then besides that, delirium.
What about depression? Delirium with depression, how do you differentiate?
Delirium with depression.
Yeah.
Yes, delirium with depression also. Depression usually it's not a sudden onset, and also if based on emotionally, maybe delirium. Sometimes patient does not have like patient that is delirium. Usually their behavior is usually like more aggressive compared to like depression patient. Their behavior is more like to withdrawn or a depressed state.
So-
And
All right. In primary care, what sort of instrument or what sort of resources do you use to diagnose delirium? Like you are examining a patient in an aged care home, huh? And
okay.
yeah, so what sort of method or instrument will you use to examine to diagnose delirium?
The instrument that I will be using to diagnose delirium.
Yeah, when I say instrument means something like mini mental state exam.
Yeah. Maybe like
Mini mental state is useless lah. You don't use it to examine delirium. But from your experience, what sort of thing like bedside, diagnosis can you use? What sort of tools can you use?
For delirium, if I'm not mistaken, the like a confusion assessment method.
Yeah. Okay. Good.
Okay, but I don't remember the component
Any
inside.
other things you can use?
I think besides that, maybe assessment like maybe doctor like a clock drawing test, or maybe MOCA, or maybe geriatric depression scale also, to differentiate between
That's all right.
depression.
That's good.
Okay.
Then what investigations will you do for this particular patient, for Joan? What would you do?
Okay. For this particular patient, I think in my clinical setting, I would like to order for a full blood count to see
Okay.
if there's any infection ongoing. Her renal function test and also her urine and electrolytes to see if there are any electrolyte
Can you show
imbalance.
the electrolytes to this doctor, please? Is there a slide on electrolytes? I think there a slide here for the electrolytes. Did we keep a copy of?
Hold on, eh?
Mm. Yeah, so this is the result you got. So what is your impression?
Patient is having hyponatremia. I think severe hyponatremia. Yeah, I can only say that of the severe hyponatremia.
Yeah. Do you know what are the different types of hyponatremia? And what do you think this particular patient has? Do you think, how would you treat this patient then?
If in this kind of situation, I would definitely have to refer this patient to the emergency department since the student is very low and she's already having delirium.
That's right. Do you know the different types of hyponatremia? Do you have any idea? It's okay, we can go through it. Yeah.
I
You
think
done?
maybe
Yeah, you done well. Don't worry, you done well. Okay, so
if I'm not mistaken, doctor, it's like true hyponatremia or pseudo hyponatremia, but I'm not sure. I mean the causes, so I can't really remember how to like categorize it.
Never mind, we'll teach you
Okay.
we'll teach you. This is part of learning, it's okay. Under exam tension, it's okay. So yeah, so that's how so we go to the slides. So this is hyponatremia. I mean, this is delirium, and we'll go to the next one. Next slide. So delirium can present many ways, but it's usually acute onset, and the delirium is very, it's reversible, so it must be diagnosed. 70% of cases of delirium they don't know the cause of the delirium, and 30% of cases of delirium referred as depression turn out to be 30% of cases of depression turn out to be delirium. So delirium is something that it's easy to remember with the mnemonics, DEMENTIA. So the differential diagnosis. I think D for dementia, then E is endocrinopathy. I think D for depression, M for metabolic disorders. Then N is nutritional, T is trauma, I is infection. A is atherosclerosis. So just go on to the next slide, please. Next one. Go on, next one. So these are the tablets she has. Just see. So this is probably, she's got crackles, so she might be having what do you call it, heart failure and all that. Fine crackles. So fine crackles can cause delirium. Any sort of organ failure can cause can cause a delirious condition as well. Next one. So these are the questions I asked, resources, and then so differentials will be using the mnemonics. This one is easy question. Next. And these are the differences. See that? Delirium, dementia, depression, and there is psychotic. So the main thing here is fluctuating. And they talk nonsense, incoherent. The speech is incoherent, poor attention as well, very poor attention. You can see probably the poorest delirium. Hallucination can be seen in all of them, but this one is the only thing that's reversible. Acute onset and poor attention. Okay, go on next. This one is another table showing. Okay, next. So global, see that DE drug induced. Don't forget, 30% of delirium is drug withdrawals or drug intoxication. Hypothyroid, metabolite, electrolyte, nutritional, B12, trauma, where your subdural, the infections. Okay, resources you use DSM-5. This is the best confusion assessment method. Go on. Then these are how I marked it. Okay, actually, this case is SIADH. Okay, go on next. Resources. Let's go on. So this one very easy to remember, DSM-5. Remember the mnemonic, A, attention, and awareness. Attention, direct, focus, and shift. Awareness is to the environment. B for baseline. B for baseline, attention, and awareness gets developed over a short period of time and fluctuate. So A, B, C, cognition. Memory, disorientation, MAD, memory, ability, visual, disorientation, language, perception, hallucination. D, you must exclude. DSM-5 can always exclude. So A and C cannot explain by neurocognitive or coma. E, that evidence not only from history, physical exam, and laboratory, that is a direct consequence of must be a medical condition or 30% of cases intoxication or withdrawal. So remember A, B, baseline, C, cognition, D, disturbances not explained, E, evidence from the A, B, C, D, E, easy to remember, DSM-5. Go on. Next slide. This one, CAM is the best. So CAM, they found that it is 94 to 100% sensitive. Sensitivity is the ruling out, isn't it? Specificity is ruled in. So in this is 94 to 100%. So their feature, this is A, attention. This is B, is the baseline changes. So these two must be present. And then they're cognitive. They don't take all four. They take only disorganized thinking, rambling and all that. Then they tell you the altered level of consciousness. So here you see 1 and 2 must be present, then 3, either 3 or 4. So this is the best. 5 minutes, you can do this method in 5 minutes. But CAM is a very good method, the best actually. 94% to 100% sensitive. That means 6% you can still miss out 6% of delirium can be a false negative. Next one. Next one. This one, AMTS, RO, all this, next one. This is other method. Just remember 2. This one, orientation, mini-cog invention, registration. You must ask the patient until you repeat. Cog drawing. Just recall sometimes. Recall susah. Sometimes I also cannot recall the 3 objects because after we tell them, we cannot recall what. Okay, go on. Next one. So risk factors. Okay, go on. Next. So, say delirium, you must know what to do. In this case, all these are the investigation. You must rule, you must do all this to rule out brain tumors as well. Go on, next. So once you see, this is Butter and Schwartz. Butter and Schwartz in 1985 says that the serum sodium must be low. So there's hyponatremic, the hypervolemic, which is seen in heart failure. Then the euvolemic. How do you differentiate hypervolemic and euvolemic? Is hypervolemic, they have both have weight gain, but in hypervolemic there's edema. In euvolemic there's no edema, and then in the hyponatremic is weight loss. It'll be in the table, and you can see that osmolarity here. So when the serum is low, hyponatremic, during osmolarity, I mean this is too much water. The body should throw out the water. But in this case, the water is very concentrated, no? Because of the inappropriate ADH. So ADH, they act on the collecting tubules, so they preserve the water. So this one get very concentrated. Urine osmolality 140. And same with urine sodium also. Urine sodium is also increased. So when you get this one, serum osmolality, urine osmolality, you see this, you know it's SIADH. Next. So Schwartz, Butter and Schwartz, 1985. These are the things that, But there's false positive for hyponatremic. So I show you the next slide. Okay, go on, next one. See, osmolar gap. So you measure serum osmolality using the lab, and then calculate serum osmolality. You calculate 2 times sodium plus glucose plus urea. So the difference between these two is called osmolar gap, and they shouldn't be, the normal range is less than 10. If it's more than 10, that means it's due to these 4 substances. See, P, L, A, N, plan. There must be a plan. See that? When the osmolar gap is more than 10, there's plan. So if your lipids are very high, it can give rise to hyponatremia. If you are alcoholic, you see alcoholic, they're always hyponatremia. It's false because they got high osmolar gap. And then asymptomatic, hyponatremia, the brain can protrude through the foramen magnum, so they can die of acute respiratory depression. So you must admit them. And then depends on the onset. If the onset is very severe, very fast, they drop. So in one day, they drop from normal 135, they drop to 110. The rapid drop can cause a severe, can be very drastic. But if patient is having 126, 27 over years, that's different. A person who drinks alcohol, their sodium is always low. So that's okay. But if the case is a sharp drop, then the acute onset is very important. Okay, next. See, I told you here, weight gain, edema, hypovolemic. So this is all the failure. Heart, kidney, liver, all this. Euvolemic SIADH, see that? SIADH, they cause, so you have to restrict fluid. Hypovolemic is easier, people with diarrhea, vomiting or diarrhea. So all this will be sent to you all, the slides. These are all my own slides. I drew it up. Okay, next. So you see, you see, weight gain, just by just pressing the legs, you know whether the patient is having hypovolemia or euvolemic. Osmolar gap, you know, we said earlier, the difference between measured and the thing. Okay, next. These are the continuation of the thing. Next. What's your diagnosis? So in this case, it's SIADH. Then my mnemonic SIADH. S syndrome. This was sarcoma, sarcoidosis, infection. This one is, you won't see anywhere. This one is my own mnemonic. I make it up. Okay, next. Drugs mnemonic also one. So in this case, citalopram. Citalopram is the cause of her SIADH. SSRI. Yeah, it causes her to have. So this one, it's an interesting case. But in this case, citalopram is the cause of it. SIADH. Then you can read about. Okay, next. See, exclude. So this is the table. Exclude underlying causes. Confirm SIADH. Butter and Schwartz. Asymptomatic. Fluid restriction. But in this case, he's symptomatic. And very short, so severe. So this one you must admit the hospital. This one. Okay, next. So step 1, differential. Step 2, history, physical exam, investigation. Then you get hyponatremia. Step 4, SIADH, investigation. Then you management of the case. Okay, next. This is confusion in elderly with confusion. So talking nonsense, they can be poor sleep, but the CAM is the best method. CAM 1 they found to be unanimously the best method to diagnose, to diagnose delirium, bedside 2, instrument to diagnose. And you must know the resources, because you cannot tell the examiner, oh, I refer to the internet. Yeah, then the examiner asks you, yeah, what are you looking at? What sort of thing? Then you must say CAM or DSM-5, and you know ABCDE, attention, awareness, baseline, cognition. Then you must exclude D, and then E must exclude. Then you must exclude the coma as well, and any neuropsychiatric states. Again, the evidence is from your history, physical examination, and also investigation as well. And no hyponatremia well, because hyponatremia is the commonest electrolyte problem in all aged care home and old people. So you must know how to diagnose and treat hyponatremia more than any other electrolytes. It's a very common problem, and so many alcoholics they have hyponatremia. Liver cirrhosis is about hyponatremia. Thank you very much. No,
Thank you,
good
Dr. Chen.
luck on your exam. You've done
Okay,
well.
thank you very much.
Thank you. Next.
Hi, Doctor.
Okay. Next, Aisha.
Hello, Aisha. How are you?
Hi, Doctor. Hi. Good, Doctor.
Yeah, we'll do case 3. So thank you for volunteering to do this case. We'll show her the candidate.
So your 5 minutes start now. Your 10 minutes start now.
I'm Miss Alma. I'm Dr. Aisha, your attending doctor for today. How are you?
I'm in pain, doctor, and I don't feel very good.
Oh, okay. When you mean pain and don't feel well, can you tell me more? What happened?
So I don't know. I just wake up this morning. I feel
Hmm.
I have this. The doctor say I have this chronic pain. They say I got endometriosis, I think they say.
Ah,
And then
I
yeah,
see.
pain.
Mhm.
I think I don't know whether it's my endo playing up again, or I don't know whether it's some other thing that's playing up.
I see. Okay. So at the scale of 1 to 10, 10 being very painful, 1 being like it's a terrible pain. How where you will put the score of the pain?
No, actually, wake up the last 2 days. I think it's almost 9.
I see. Okay. So it's 9. So have you taken any medication? Have you seen any doctor because of this?
No, I was busy, doctor. I says I had my daughter, to look after, and I'm single mother. I took,
I see.
I
All
I
right.
took some
So
Panadol.
you mentioned just now. I see. Okay, you mentioned just now your a doctor have mentioned that you have endometriosis, right? And I was informed that you took some OCPs before this oral contraception, but have they given you anything else?
So all the while, I don't believe in medicine, doctor. I think I can put up with the pain.
Mm,
Yeah, I
I see. And any particular reason you don't believe in medicine, Madam Alma?
no, I just don't like taking medicine unless I really need to take it.
Okay, so you mentioned that you have endometriosis. May I know like you're having your menses right now? You're in how many days are you in already?
Oh, I think I'm not having. I think I had my menses just 2 weeks ago. I don't think it's the menses that's causing the pain. No, this one is a bit
Hmm.
unusual pain.
Okay. Do you notice that you have any like fever in particular?
I did have a fever. I recorded
Mm-hmm.
it was like 38 degrees, I think. Then I took some Panadol.
I see. Do you have noticed any bowel change?
Bowel change I had. Not really, but it's just, yeah, I don't think there's any, it's just the pain is more on the lower side of my tummy. But I don't
Okay,
think
how about
I haven't been to the toilet for maybe 1 day.
mm-hmm. Okay, how about your urination? Do you have any painful urination?
No, no pain when I urinate.
Okay. So Madam Alma, I just want to ask you some sensitive question. It can be a bit intrusive, but I do ask this question to a lot of my patients to assist my diagnosis. It's regarding your sexual activity. Are you sexually active right now?
No, I'm not sexually active. My last sexual partner was 5 years ago.
Okay. Do you have any particular do you have any history of sexually transmitted disease?
No, I don't remember. Yeah, I've never had. I don't remember being treated for sexual transmitted disease.
Okay. So you mentioned you've been having this endometriosis for quite some time. How does it affect you in general?
So yeah, I think they did a laparoscopy on me and they said endometriosis, but I think I can put up with the pain. The pain can be very bad when I have my menses, but in most cases,
Mm,
yeah, the last I would say few years, I try not to take medicine.
I see. All right. Madam Alma, just like a few question more. Because you said that you don't take any medication, right? Can I just want to ask regarding that even further. Is that okay? Anything in particular, like anything that you're concerned of that you maybe want to tell me?
About what? Sorry.
Because you mentioned just now, you don't believe in medication, to help your endometriosis. Is there anything that you are worried, you're concerned?
Oh, no. I just like take herbal medicine. No, I like to be on natural medicine. Yeah.
Okay.
I like to take those.
Okay. How's that going? Does it improve your symptoms?
I think it does. Yeah, but I think it does. But today's pain is last 2 days is very painful now.
Okay, all right. Madam Alma, I think we need to proceed for further physical examination, and I'll need to do some investigation on you. Is that okay?
Yes. So what examination will you do for the
Okay.
for
All
the
right. So I would
patient?
like to see patient's general condition. Is patient obese or lean? Is she thin? Is she how's the hydration? And then I would like to just generally see how's the mood. And then I would like to see patients to check patient's vital sign, BP, heart rate, temperature, SpO2. Just want to know patient's BMI as well.
So she's the BMI is around 32, and her blood pressure is slightly higher, about 142 systolic, and diastolic is 76. Fever, she's still having a mild fever, 37.8 degrees, and the pulse is a slight mild tachycardia, about 95 per minute, regular rhythm.
All right, I would like to do a focus examination on the abdomen. Is there any distension, any scar marks, any tenderness at the suprapelvic or any parts of the abdomen?
So the abdomen, there's tenderness and the lower abdomen from the all lower abdomen is tender.
I would like to do a lymph node. I would like to check is there any presence of lymphadenopathy at the neck, at the inguinal, and I would like to do a pelvic examination. In particular the genitals. I would like to see is there any discharge coming up from the vulva area.
No discharge.
And then I would like to proceed with bimanual examination with patient consent
No
with
mass
the chaperone.
no adnexal mass is felt.
Okay, so for the bimanual, is there any cervical excitation?
No
Any sorry, doctor?
No pain on rocking the cervix. No pain, no tenderness.
Okay, so I would like to just want to see like the skin. Is there any like rashes in particular?
No rashes.
Okay, so I would like to do an investigation. I would like to see the FBC, any raise. I would like to check the RP. Is there any possible of an AKI? I would like to check the uric FME as well. Is there any yeah, that I want to do.
So the
those
full
two
count
first.
is neutrophilia 78%, and the white blood cell count is 12,000. But the urine examination is normal.
Alright. Okay, I will do an ultrasound, transabdominal ultrasound as well. Is there anything can be seen?
Ultrasound, very bulgy abdomen, that's not very clear, not unable to make out any.
I see. Okay, all right. So, Madam Elma, from your investigation, I do have like few things that I'm thinking of. It does have related to your endometriosis. Okay. So I'm thinking about it could be you're having like pelvic inflammatory disease, which means there's an infection at your endometriosis that could cause you actually the pain. So with this, actually, we do need to give you some IV antibiotics, which means I do need to admit you to the hospital. Okay, so if let's say we don't treat this, it could actually cause even further it could worsen the condition. It could go into sepsis, which means the infection goes into the blood, and it could actually affect your fertility as well.
10
Okay, I
minutes.
do I okay. Alamak.
Okay, now we just this is an exercise for lower abdominal pain in reproductive women. So when you look the thing, you know that. So this is a case where you know she's reproductive age. So everything notice the age and the thing. Just like the child, the first one, 3 years old, you already know. You form what opinion, what are the possible diagnoses. So this is a reproductive woman, and she's having lower abdominal pain. Okay, next. And she complains of cough and fever, so she got COVID. But so there's just widespread tenderness, lower abdomen. You must ask for rebound tenderness, but did you say? I can't remember whether, yeah. So
Yeah,
rebound.
I didn't ask.
Yeah. So there is that. Sorry, I didn't hear. So it's rebound tenderness. There's temperature there. Okay, next. Other symptoms like, so this is a high white cell count. No analysis, Actually, it's a case of appendicitis, but it's okay. I will go through the exercise, but the exam can twist the diagnosis. Can twist the diagnosis. Okay, go on. Sometimes we miss appendix can be very normal, but we'll go through it a very structured way. Of course, me as a examiner, I write the case easy to say, but if I'm sitting in your position, I also will miss it. Anyway, let's go on. Next one. So examination and what's your diagnosis? Okay, go on next. So in the most important thing, as in anything like the Tom J, remember we said trauma and then osteomyelitis, septic, malignancy, and disaster. The most important is the red flag. So you must rule out appendix, ovarian torsion, and you must do a UPT. Although the first case is not sexually active, but you still must rule out. You don't trust the patient sometimes, so you must still rule out ectopic. STI, you did very good job. You did it. She's a case of chronic pain, endometriosis, but in this case, yeah, PID. So these are very women-specific things. And then renal is you did ask for UTI, pyelonephritis, fever, chills and rigors, and tenderness in the loin. You must mention pain when you put that. And then these are the physiological pelvic pain and mid-cycle. Okay, let's go on. So the most important thing is in appendicitis, there's called Alvarado score. Have you heard this? 80 to 85%. So this is the most popular one. So this sensitivity is 85. That means you get 7 is likely, intermediate. So in about 10 to 15% of cases where the points are less than 7, you can still get a false negative in appendicitis. But the ones that carry 2 points are WBC count and tenderness in the right iliac fossa. See that? So there are some, I saw one appendix, so the tenderness not there. This can use as a guide. I mean, sometimes when you land up in court, you miss appendicitis, then you have Alvarado score. At least it shows that it's a very systematic approach to a diagnosis. So fever, abdominal pain, then it radiates to right iliac fossa, or rather umbilical pain, periumbilical pain, loss of appetite, nausea, vomiting, 1. So you add up all the points. If it's 7, it's likely. Ectopic, you must do at least a UPT. Then ultrasound will be empty uterus. Okay, let's go on. Next, ovarian cyst, unilateral, sexual. We did ask for it. Next one. And women specific. Then we did ask for this pain, but all. Remember all the D's, dyspareunia, pain on deep intercourse, pain or dysuria also can happen, endometriosis. All the D's are dyschezia, painful defecation. Then so these are all the sometimes you can't diagnose any condition detected in 70% of PID. Endometriosis. All these are dysmenorrhea. Okay, next. Pathological, then these are the renal things. UTI, so uncomplicated but complicated UTI. So these are important things to remember. Next. And these are the physiological for abdominal pain. So there are 5 things: the emergencies, STI, and then women, they are specific, and then UTI and pyelonephritis. Then women is physiological. Step 5 is physiological. So it's only 5 differential big umbrella group of pain in reproductive age. Go on, next one. Is that the next one? So this is my mnemonic, the site, SOCRA, Socrates, in the history. Next. Right iliac fossa. Okay, go on. This umbilicus to right iliac fossa. Right upper quadrant, you get PID. Okay, next. 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 Go on. Next. So endometriosis occurs 1 in 9 women in Australia. So very common here. Next. So the OCP, the hormonal, it does help, but that is not the answer for it. But it's either medical or surgical. Next. So these are the way I mark it. Differential diagnosis, you must have. And the history taking. Next. Diagnosis. So okay, this is an important thing which I want to emphasize. So the patient asks for painkillers. They want Betadine, they want codeine, DF118. So how would you know? How would you approach a case that patient asks you? Say in the YWA, they ask you, patient walks in, they wanted DF118. How do you assess whether the patient, is so go on, next one. So when you use opioids, these are all the flow chart. Okay, next. These are the flow chart for the one low abdominal pain. Next. Yeah, so it requests for painkillers. So you know what are the types of painkillers, what strengths they are, the mild and then the moderate severe. Next one. So this one you can use an opioid monitoring tool, and every doctor should know at least to score this. Activity, analgesia, aberrant behavior is important. So at least mention this tool is important. Opioid monitoring tool. Next. Okay, so you know this opioid monitoring tool, and then you score the points. Let's see, next one. See that again, the sport important. So if you have a 90, if you have scored more than 8, that means this one is probably drug addict. So it's important to know opioid risk screening tool. At least just know one tool. This can ask in your YWA or diary, practice diary. Okay, next. Yeah, okay. So basically, it's female health with other differential diagnosis, and then, okay, you've done well. No, very good. Good luck in your exam.
Thank you, Doctor.
Thank you.
Thanks, Doctor.
Yeah, we go on to the next one.
Okay, Amira, are you ready?
Yes.
Hello, Amira.
Hi, Doctor. Hi, how are you?
Good. Thank you for volunteering for this case. We'll do the reading.
Okay.
So your 5 minutes start now. Your 10 minutes start now?
Okay, hi, Miss Sarah. I'm Dr. Amira. I'll be your GP for today.
Yeah, just doctor, I need your help, doctor. It's just I'm feeling so tired now. I don't think, yeah, just the last few months has been very tired, aches and pains, and yeah, just wake up. I feel that, in the afternoon I have to go back and sleep again, for another 2 hours. And I sleep well. I don't know why I still, in the afternoon I need to get an extra sleep.
Okay, I'm sorry to hear that, Miss Sarah. Do you have any thoughts of what could be leading to this problem, Mrs. Sarah?
I don't really know, I just lack of energy. I don't know why, daytime as well I'm sleepy, and I don't really.
Okay. Do you have any specific thoughts or worry about these issues that you've been having?
Well, I have 3 children. I divorced from my husband 5 years ago. My 3 children, they are all in school. They they are between like 14 and 10 years old and 7 years old. To have to look after them, send them to school, and I guess, but as a single mother, I think it's a bit tough on me. But then like doing it the last 5 years.
Okay, I can see that you are concerned regarding this, Mrs. Sarah. Can I ask you a little bit more questions? When you mentioned about you don't feel quite right for the past 4 months, has the symptoms been gradually or is it getting worse as of late?
Yeah, it's probably about the same. It's plateaued, but in the past 4 months, I'm tired.
Okay. Do you feel like you have lost interest of the things that you previously enjoyed?
Yeah, that's what my other doctor across the road, they told me when I'm feeling very anxious, and they've actually started me on the citalopram, but it's a very low dose, 10 milligrams.
Mm-hmm. How does the citalopram affect? Do you have any side effects? How do you? Are you okay with the medication?
Yeah, I just feel a bit funny on citalopram as well. I just feel like it's giving me that sort of like, but I've been on 10 milligrams of citalopram the last 2 years, So maybe
I
over
see.
the last 2 years I'm getting used to it already, But initially when I started, I feel a bit funny with the citalopram, a bit
Do
drowsy.
you,
Yeah.
how's your previously you mentioned that they started you because of you feeling anxious. How is it? Does your how do you feel now? Do you feel on edge at times? Do you have the anxiety feelings?
Yeah, I still feel that. I'm not I don't feel like, I feel that I'm doing too much as a single mother.
Okay. I'm sorry to hear that, Mrs. Sarah. Some other questions, maybe, do you have any, about your muscle aches and pains? Do you have any specific points of your body that, is giving you more trouble?
Very weak points are my shoulders and my hips, my knees and my front part of the chest, but it's just muscle aches. It's just aches and pains.
Do you feel like the pain is more worse, any certain time, or is it, throughout the whole day?
The pains, they probably, yeah, they come. They come on more when I'm a bit more anxious, huh? But otherwise, I think I can put up the pain.
All right. Okay. Have you tried taking anything for the pain?
I'll just take some Panadol for it.
Okay. All right. So another thing, do you notice that you have any recent symptoms of your mood become very elated, you have excessive spending and things like that?
No, I don't think so. No.
Okay. All right. How's your sleep like, Mrs. Sarah?
Well, I sleep. I sleep very well, but of course, in the weekends I do enjoy a bit of my alcohol. But I drink only on Saturday and Sunday. I have about four. I have about 4 drinks in the weekends. Weekdays I don't, because I have to send children to school.
Okay. How about is there any loss of weight, loss of appetite, any night sweats? Do you experience any of those?
No, I don't remember.
Okay, all right. How's your energy level, Mrs. Sarah?
Very low energy, very tired.
Okay, Mrs. Sarah, is it okay if I do some investigations before we come into a conclusion of what you might have today?
Yes.
Okay, I would like to do investigation. Is there any mental state examination? Any GED score? And then is any FBC, renal profile, liver function test, ESR, CRP given?
Okay. The results will show you the list of the results. We can show her the results now. Is there a result listed? Yeah.
Okay. Okay.
So doctor,
Okay.
so many red marks, doctor, in my report.
Okay, Mrs. Sarah, it looks like there are a few things here from your blood test. First of all, it looks like your kidney is a bit on the low side. The kidney function rate is a bit on the low side, and your sugar level also is high, and also your cholesterol level and is also on the high side. And plus you have there's a presence of protein inside your urine as well. And have you done any blood tests before, Mrs. Sarah?
Oh, the last blood test was before I divorced my husband 5 years ago.
I see. Okay. Do you do any physical exercise, Mrs. Sarah?
I'm on the Diabex, 500 milligram twice a day. I'm taking my tablets.
Okay.
Take metformin. And yeah, I take only metformin and Somac, pantoprazole.
Okay. Okay. All right. So, Mrs. Sarah, it looks like your blood levels are not in good side. Okay. So maybe what we can do is there are a couple of things that maybe we can address here. First is your cholesterol level. I need to start you on a medication called statin. I'm sorry. Can I see the patient's medication list?
I think it's on the front sheet, the first sheet.
Okay.
Although here, you see here, the
Oh, okay, thank you. Okay, all right. So I need to start you on a statin. It says medication to reduce your cholesterol level. We can start with atorvastatin, 20 milligram. And I need to increase your sugar medication as well. We need to aim your HbA1c around 6.5, 6 to 6.5. I might need to increase, maybe we start from increasing the metformin to 2 tablets. We can increase to 1 gram morning and night first. And then from there, we can evaluate further. And then from there, and then another thing, it looks like maybe I can add on one medication called Farxiga. It's a dapagliflozin. Is a medication for diabetes as well. It can help to slow the progression of your kidney disease as well. And I need to monitor you closely. I need to repeat all your blood tests in 3 months' time, just to see whether you are improving. The blood test is getting better or not. In the meantime, I will also want to refer you to psychologists. Also we can for cognitive behavior therapy for your mental health well-being. I will also would like to advise you for regular physical exercise if possible, maybe 150 minutes a week. And we can also discuss about your diet. Maybe we need to cut down on meat, high fat food, increase your vegetable intakes, decrease your salt intake as well. And I see that you smoke about 7 to 10. Okay.
It's up time. So here also there's COVID infection. She had COVID infection as well 5 weeks ago. So now you all go and read up. Can we have the slides? So this one is long COVID. It is probably coming up it's one of the hot topics for exam. So try to read up something about what long COVID is. 60% fatigue, 30% shortness of breath, and so you must ask them to what is the fatigue. I mean, this occurs in very common. Fatigue occurs in about 1/3 of our GP patient. They can't initiate, they can't maintain, and then there's concentration and memory. Then you divide into acute, subacute, and chronic. Then go on. So see, very common. 1/3 of our patients, or 1/5, in our GP setting has. And then when you get it, you say, "Oh God, why again another fatigue patient?" And next one. So these are the things that you will go through. But I think Amira must do at least a physical exam. Don't miss out because this one there are certain points, right? So from history jump to office, you must always include, make it a rule from history, and then sometimes get carried away, in the exam pressure, then we tend to miss out this one. Then they will penalize you if we don't do it. Okay, next. Red flag. Always remember red flag, then other medical. So these are my steps. Red flag, biomedical, then social and psychological, then your lifestyle, then the unknown cause. Okay, go on to the step 1. So these are the red flags, the alarm. The age patient, loss of weight, anemia, abscess, arrhythmias. Then they are on malignancy symptoms and signs. That means either lymph nodes or it's jaundice or ascites or hepatosplenomegaly, shortness of breath. It can be tiredness as well. Even rheumatological, celiac disease, multiple sclerosis, Parkinson's disease, they can be tired as well. Next, step 2 is common factors. So anti-epileptic, you take propranolol. Propranolol can make you very tired as well. See, long COVID. So when you have the list, you must study. Long COVID is possibly one of the favorite questions that's coming up in exams. It's 3 months. After 3 months after having COVID, you still have symptoms. Type 1, type 2, type 3. B12, also common, not common, but it can be macrocytic anemia. It can be one of the causes of tiredness. Go on, next. Next, then this is the big list that you can read up about it. Sleep apnea, don't forget, snoring the sleep. I think the 6 common causes of tiredness, according to one author which I read, Australia, is sleep apnea, depression, mental health, and then any stimulants they take, you keep you awake. Even weight reducing pills will keep you awake. Then either you're happy at work, unhappy at work, or you've been bullied at work, or you have the sad PTSD. Next, or your lifestyle, you just can't sleep, play with mobile phone too much, sedentary lifestyle, no exercise, drink too much, go on drugs, inappropriate diet, the lifestyle. Step 4. And step 5 is, go on, next one. Is chronic fatigue and fibromyalgia. So there are 5 steps for approach. This is my approach for fatigue. Next. So these are the things that you will look at for under examination. And okay, next. Anemia, infectious disease. Don't forget. HIV, TB in our country. Mononucleosis. And this is the medicine, rheumatology, drugs. Don't forget toxic drugs. Next. This is the criteria 2015 for chronic fatigue syndrome. Next. Long COVID, 60% fatigue, shortness of breath, joint pain, chest pain, cough. Next. Also long COVID. Next. Must read out a bit of long COVID. Then postural, orthostatic, postural orthostatic, the syncope, POTS POTS, 10, 20, 30 beats per minute, 40 for patients less than 20, 10, 20, 30. Just remember, 10 minutes of standing, 20 years. This is for diagnosis of POTS. This is seen in long COVID as well, alongside with palpitations. Next. These are long COVID, notes on long COVID. Next. So this is renal. So renal, you can see, that the macro. So that case, I had macroalbuminuria, because one is 46. Then you look at the GFR. I think they are 46 here. So it is 3A, orange. His macro, how much was his albumin just now? I can't remember now. But anyway, this is how the amber, green, amber, and red. Okay, next. So this is very important. Any case of CKD, again, mnemonics very important. A, B, C, D, E. A for AKI, the red flags of CKD. Every patient with CKD must know A, B, C, D, E. A for AKI, they are prone to develop AKI. B for uncontrolled resistant hypertension. That means they're about on 3 drugs on which you must include a diuretic. You must try it for 1 month and you can't achieve 140/90. So this is the definition of resistant hypertension. C for they have more chance of cardiovascular disease. D for drug reaction. E for end stage. F for 5 or more metabolic abnormalities. Low hemoglobin, acidosis, potassium phosphate, PTH. So remember, A, B, C, D, E, F, 5 or more. So these are the 6 red flags of CKD for every patient. With CKD, you must look for the A, B, C, D, E. And this is what I encourage all my doctors. Actually, I'm writing up a monitoring outcome for all my doctors in my medical center. I want all the doctors to look for these 6 red flags in CKD. Next. CKD. Next. So if always we think diabetic have kidney disease, but in this case, what are the things that tell you that it not due to polyfactor to be positive other etiologies? So if there's no retinopathy, if there's lots of albumin, if acute kidney injury, and if the diabetic duration is less than 5 years, or hematuria, or systemic disease, then you know that it is other factors that can cause acute kidney disease as well. Okay, next. These are just treatment for things. So in that case, the patient also got hyperuricemia. No? Go on next. Next, this is the marking scheme. Go on. This on the slide I show you. Okay, go on. Is there a slide? In hyperuricemia, in allopurinol, they should not use your allopurinol. In that case, that chart, I think we had the uric acid is higher. Yeah. So you see that you must maintain reduce this by, and then EGFR is 45. So when you see the uric acid is high, 4 millimoles. So normally in patients, if they have gout, they must use 1.5 times allopurinol dose, 1.5 times the EGFR. So if your GFR is say 30, then you can 1.5 multiply by 30. So you can use allopurinol only up to 45 milligrams. So allopurinol is one of the can cause adverse drug reactions in CKD. So you must remember 1.5 times the EGFR for allopurinol, but you can use a drug called febuxostat. HbA1c is high. If you use what did you say is SGLT2, isn't it? It can reduce up to 1.5% of the HbA1c. So if you use SGLT2, or you can use injection or Ozempic, you can reduce it 1.5. But if you use DPP4, you can only reduce it to 0.7%. So DPP4 like linagliptin, all this, they are milder, but Ozempic is very good. They can reduce it up to 1.5 with SGLT2. Metformin, you must be careful. You make sure that your creatinine clearance is good, because you don't want. Yeah, I think contraindicated if creatinine clearance is less than 30. Then if we use a statin, like you said, the statin can reduce it by the LDL, which is a surrogate marker for heart disease, by 20 to 25%. If you can't reduce it, you can't achieve the target, you add on Izetrol. Izetrol will reduce it by another 15 to 20% of their LDL. So statins alone can reduce to 20 to 25, but Izetrol can reduce 15 to 20% on top of the statins. This one, no drug can increase HDL, must exercise. This can be because of uncontrolled diabetic, because triglycerides are elevated. So not all your metabolic things high. This one can appear as a long case. Amira, this one is a long case. So you get a double station, and then these are all metabolic GP work, These are creatinine, renal. I purposely put this in so that I have a chance to discuss. This is a common thing that come out. They seem to examiners like it. They like to ask all this. They see how you twist and turn with the metabolic things, or how you handle them. They must know what are the medications you use and all that. Okay, thank you very much. And then
Thank you, Doctor.
you also brought in the physios, and you try to increase allied health, nutritionists, allied. So as a GP, you must get a multidiscipline thing, psychologist, all that. So you did help to improve that's how you must bring in. Every time you talk about this, multidisciplinary care, not just we all GP, but you must bring in the psychologist, the nutritionist, the physio, exercise physio, gym membership, all this can be. So it's a boring thing, but it's part of our GP life, fatigue and all that. Thank you and good
Thank you,
luck.
Doctor. Thank
Thanks.
you. Thank you so much, Doctor.
Yeah, you go to the next one.
Okay, the next one we have Kesa. Kesa, are you ready?
Yeah, I'm ready, doctor.
Hello, how are you?
I'm fine, doctor.
This one is adolescent, very naughty girl.
Oh, okay.
5 minutes starts now.
Okay, sure, doctor.
So sometimes the thing helps you, in that 5 minutes, right? You think, it's a waste of time. The reading also, it doesn't give you any clues. Like the first case, the leaping child, you must start thinking the 1 to 3 years, what are the possibilities, 1 to 5 years, And then the female case, you must think, reproductive, the age and all that, reproductive age, And then the elderly woman with confusion. So the age group is important here. In this case, it's quite straightforward, this one. And this is a common problem. This has become an international problem. And you must study hard for this. You must learn how to assess and how to approach. It comes up in the Australian Family Medicine recent article. Examiners like to ask questions on the recent article because they tend to refresh themselves and then they set a question around there. So I don't know. I'm not in the examination board anymore, so I don't know. But I like to discuss this thing with a lot of my patients, and I think you all should read a bit more about vaping. Very important and topic internationally.
Can I go to the next page, doctor?
Sorry,
Next page. Is it only one page?
I think so.
Only one page.
This one is quite.
Okay.
Yeah. So she comes from a separated parents.
Okay.
She's 15 years old. That she's the only child. Mother is a hairdresser. Shared care. Sometimes stay with the father in the weekend. Sometimes stay with the mother. Real story, this one, but different names. This is actually one of my patients.
Your 10 minutes starts now.
Okay. Hi, Azmina. I'm Dr. Kesa. How are you today?
My mom asked me to see you.
Okay. So, do you know regarding what you need to see me?
She's not happy with me. She says she saw something in my school bag and then she wants me to talk to you.
Okay. So, do you have any idea what she found in your bag?
Vaping, doctor, I think my friends also do it. Everyone doing it in school. I don't know why my mother so upset.
Okay, I understand that you are stressed now, but just Azmina, before I start talking this discussion, I would like to tell you that whatever we are discussing now or we are talking now is actually confidential. So I won't I won't tell your mother. So you can talk to me. So can I know have you been vaping actually?
Yeah, I vape. My friends all vape.
Okay, so when did you started to vape?
I started last year, doctor.
Uh-huh. Okay. So is there any reason why you started?
I'm stressed. I'm just stressed at work, stressed in my school. And then I saw this thing my friend say this one, when you vape, my stress is disappear, no? And the flavors are very nice. I like the strawberry, the fruity flavor.
Mm-hmm. Okay. So how often do you vape actually? How many times? How many puffs per day?
About 200 puffs, doctor, I use. One day I use 200 puffs.
Oh, 200 puffs. Okay. So I should ask you, Azmina, do you know any danger of this vaping? Have you anyone talked to you about this?
And nobody has talked to me, but I know it
Hmm?
is my anxiety.
Okay.
Stress is relieved, and yeah, I just transfer money to the seller, and then I get the weight. I got online account, I can transfer money.
Okay. So Azmina, since you're talking about stress, so can I know how is your home condition? What are you stressed about actually? How is it at home? How is your relationship with your mother?
Yeah, my mother, she is always busy, hairdresser. I wish leave me alone in the room. And I see my
Okay.
father only in the weekend. My father got another girlfriend already.
Okay.
My mother also got a few boyfriends.
Mhm. So how about your school? How about your school? I mean, how is your education? Are you can cope up with your education?
Yeah, I just coping lah, doctor. I'm in Form 1 now. I'm good at mathematics, but the
Mm-hmm.
other subject I don't like. I don't like all this other. I only like mathematics.
Okay. So otherwise, do you take apart is from vaping? Do you take any alcohol?
No, doctor. I don't have money to buy alcohol.
Okay. Do you have you start taking any drugs lately? Any drugs advised by a friend?
No, I don't have any drug, but my mother says I'm a drug addict on the vaping. But I don't think I'm a drug addict. But she says sometimes I look like very upset and very withdrawn, and sometimes my mother say, I play basketball and then she say I lose interest or I lose my temper in the basketball court. So she say it's my drug in the vaping. But I don't think so, doctor.
Okay. So do you how about is there any sexual activity? Are you sexually active?
No, doctor, I stay with my mother, but I like a few boys in school, but I didn't have any sex with them.
Okay, so since you're saying it's very stressful, how about your mood? I mean, how are you feeling? Do you feel any low self-esteem? Do you feel very low, very sad?
Yeah,
Is there
so
any
the
interest?
mother
Like
take
last
me
time
to
you
see another doctor. Last time I used to cut my wrist, I cut my wrist a few times already, and then I use multiple cuts, and then. But actually, I want to attract attention. I want my mother to concentrate on me.
Okay.
I don't want to commit suicide. I just want to show. I want my mother to listen to me.
I'm very sorry that you're feeling such. Okay, how about regarding your vaping? We'll come back to your vaping. So, have you tried quit vaping before this?
No, I don't think so. I like whipping. It relieve my stress.
Uh-huh.
I like it.
Yeah, but actually, Azmina, I can see in your medication chart. Okay, I can see that you have bronchial asthma. Correct. You've been on a puff at the Ventolin puff. Correct.
That's right.
Yeah, so you see, if you smoke, actually, it can worsen your asthma attack. You might have frequent exacerbations, frequent attacks actually due to your asthma. So I think, actually, if you have reduced your vaping or actually quit your vaping, maybe it'll be helpful in actually taking care of your asthma. You kept it well controlled, okay. And another thing is, I can see that you are stressed with your work, I mean, your home, your relationship with your mother. But I can assure you that vaping cannot help such. I mean, just by vaping, it doesn't help your problem actually. So maybe yeah. Are you following me?
Yeah, I know. For asthma, I got inhaler, Ventolin inhaler.
Yeah, I know you have inhaler, but the issue is what if it doesn't help you much? I mean, what if the attacks frequent? So that is although you have an inhaler, but it can actually worsen your asthma. You need to take the inhaler more frequent.
Yeah.
Yes. Are
So
you
I'm
interested in quit currently, Azmina?
interested in what, doctor?
Quitting, stop the vaping?
Stop vaping.
Yes.
Not. I don't know. I feel that I benefit a lot more from the vaping, because my stress, I can concentrate better in school also. I don't know why my mother so upset.
Yeah, but actually, Azmina, so I want to tell you that actually this vaping is not actually it's not something healthy. Actually, it can cause you more problem compared to now. Of course, you feel better, you feel less stress, but because of this vaping, but otherwise, it is causing more harm. Actually, so maybe to reduce the harm, instead of vaping, maybe can help you. Maybe you can maybe I can refer you to some psychologists actually who can talk to you. Maybe they can talk to you regarding your issues. Maybe they can give you some idea, some advice how to cope your problem with your mother. Maybe we can call your mother and you for any relationship advice or relationship counseling where you can actually talk each other and also talk to each other, and actually you can have an idea how to improve your relationship.
Yeah. So what are the other harms I get from vaping? What I mean, you said I asthma.
Of course.
What
Okay,
other
first of all, sorry.
What other things can I help? Like what sort of risk what does it do to me if I continue to vape?
Of course, first of all, second, you will get addicted to it. Another thing is you might have some gastric ulcer because vaping. Okay, and then you might how to say now, because you're just 13 and you're already smoking about 200 puffs. As time goes, you might have some other, like it also carries some risk of ulcer, esophageal ulcer. I mean, gastric ulcer can cause you also. There is a evidence showing that might be a lung injury. E-wave associated lung injury. Have you heard about it?
No, I didn't hear anything about lung injury. What lung injury?
Yeah, so we call this E-Wali, which is about e-cigarette associated lung injury, because this lung injury actually it can cause you to have lung disease. You might have shortness of breath. You might have some a cough with bleeding, cough with blood. Also, there can be a loss of weight, loss of appetite, and also so sometimes it can look like TB, or can be looks like cancer. Yeah. So actually, it's caused by there's evidence showing that it's a lot of cases that arise because of vaping. It can be E-Wali due to it.
Right.
Is the time up or?
Yeah, time's up.
Oh, okay.
Show the slide. Yeah. So this one is a adolescent problem. I think all of you should study hard for it, because this one can come in the Viva or practice diary or under preventive health. It can be. So I think the main thing is here the
So
different.
I think 3 case studies here.
Okay. Next. So step 1 is the headers. Headers is always the home, employment, education. All this needs to be. You can approach the adolescent approach, or you can use a Socrates approach for vaping history. Then your risk assessment with the alarm. Then the intervention using 5 A's or frames approach. And then you tell them about harms. So this one is a very stubborn child. She don't want to listen actually, but you just have to. You can't also force them to do at the first consult. We can't do everything, but we can. What he did was he reinforced as many things as possible, and they found that in Australia they sell actually nicotine vapes and non-nicotine vapes. So they did a random study. They found that the non-nicotine vapes also contain nicotine. And then the nicotine vapes, they also contain cannabis. Sometimes they contain drugs as well. So there are a lot of foul play in actual the thing. They are not exactly the ones which contain nicotine needs a doctor's prescription. I don't prescribe vapes, so I stay out of the picture. But this is how. So let's go on to the next slide. So the headers we must. Okay, go on. So this headers is this one you all must know it through your thing, which you have done well. She's the Dr. Kesa Watini has done all this, most of it. But the next one, but there are certain refined ways of asking questions. How you ask, poor way, better way, education, or that. This one you can tidy up or fine tune your this one the way of asking. Next. How you do a risk assessment. So these are alarms, assessment, family interrelationship, learning, educational, ADHD, whether it's got any mental health harms, aggression, forensic history, risk, medical complications, whether you use IV, mental health screening, SAD, SAD, psychosis, sexual health, which has been covered in most of the way she asks her questions. Next. What are your brief intervention strategies? So the brief that goes down next, back to smoking. The 5 A's, ask, advise, assess, assist, and arrange. Next. Frames is another way. FRAMES. Next. Harms associated. So EWALI was discussed. Next. EWALI, they need sometimes they need a lung transplant. Then you must ask them about nicotine effects and addiction. Go on, next one. So the e-cigarette EWALI, EVA, so e-vaping in 90 days. But you must rule out common things like pneumonia and COVID. And all the tests must be negative. And the eye is imaging, shows opacities. Okay, next. So it must know nicotine toxicity, to a certain extent. So patients early phase, under 1 hour, delayed phase. Diarrhea is a delayed phase, but you get nausea, vomiting. So this one is nicotine, because the nicotine, if you smoke a cigarette, 10 to 15 milligrams of nicotine, one cigarette contains 10 to 15 milligrams of nicotine, and 10% is absorbed. But in the IU pot, 5% the pot for thing, it contains 40 milligrams of nicotine. So that girl, she smokes 200 puffs in the medium strength. Is equivalent to smoking 20 cigarettes. It's not a solution to smoking. She actually has been 13 years old and she's sleeping. She thinks that 200 puffs is nothing, but actually she's smoking equivalent to smoking 20 cigarettes. And these are the nicotine toxicity that you must know, have a brief idea. Because this patient, that girl, actually she's having tremors in the basketball court and headache and all that. She's actually having nicotine toxicity, in that she's been vaping, and she has all this, And most people vape, I find that they go out, they have the withdrawal symptoms, so they need to go out and vape again. Next. Is there another one? Next slide. Oh, this is the scoring. Next. Go on. Next. No more? Finish. Okay. So remember, so you're smoking 200 cigarettes, 200 puffs is 20 cigarettes, So read out on long COVID, read out on thing. So we cover pediatric, we cover geriatric medicine with that hyponatremia case. Then we did a women reproductive age, which is a women's health with a bit of surgical thing involved. And then we covered all the common metabolic problems with fatigue. And then Kesa, thank you very much for participating. And then the last one we covered adolescent.
Thank you, Doctor.
Yeah, good luck in your exams, and thanks to all the IT team. They've given me very good support to organize this. And I won't mention names, but everyone here has contributed one way or the other to learning. It's just part of our responsibility to pass on and educate the young, love one another, and then pass information to the young, and forgive and forget. So these are the three things to remember: forgive and forget, love one another, and pass information to the young. So this is what I'm passing on to your younger doctors.
Can the participants on their video so that we can take a picture with Dr. Chen?
So I have a video, I did a YouTube on hypertension, hearing loss, and things. So maybe, if I think I had 3,000 supporters so far, subscribers. So if you want to subscribe, it's free to listen. I think it's only 10 to 15 minutes. And I spoke on liver function. That's a very long time ago. I stopped producing YouTube because the person who took my YouTube actually passed away last year in Christmas. She's a very good friend of mine. So so if you want to listen to more of my YouTube, you go YouTube and then you put my name there, Tim Chen, T-H-I-M, not T-I-M, T-H-I-M, and then C-H-E-N. Then you can subscribe. It's a free thing. You can listen on my 15-minute talk on hypertension, and think 12 minutes on sudden sensory neural hearing loss. And then the liver enzymes was long. The one we were talking, was teaching, I think, I don't know how many, a few hundred doctors, 400 doctors. So that went on for nearly about 1 hour, that will elevated liver enzymes. So I hope to do more, but I have to find somebody who can tape me again, tape me so that I can speak. Thank you very much.
Okay, just look at the screen. Okay, 1, 2, 3. Okay, hold on. One more. 1, 2, 3. Okay, wait. There's one more page. Okay. 1, 2, 3. Okay. All right. Thank you very much.
Thank you. Best of luck to everybody. Good night.
Thank you, Doctor.
Thank you,
Yeah.
doctor. Thank you,
Enjoy
doctor.
the weekend. Yeah.
So for those who wants the slide, just fill out the Google form that's shared in the chat.
Yeah, and then we comments on from you all and see whether how we can improve our presentation or how we can improve it in future. We are open to comments, so we know how we can improve ourselves in future. Thank you.
Okay, Dr. Chen, you just hold on for a while, yeah?
Yeah. Send me their comments as well. If
Yeah,
you,
sure.
yeah, and the recording later, then they can all have my slides and they can all have my notes.